Hello students, this is Dr. Barath Kumar, Assistant Professor from the Department of Oral and Maxillofacial Surgery, Vinaya Mission Sankaracharya Dental College. Today we are going to see about the mandibular nerve block techniques. The contents of the maxillar nerve block techniques include introduction, anatomy of maxilla, nerve supply, local anesthesia, intraoral techniques and extraoral techniques. First we are going to see about the introduction. We are going to see about the anatomy of maxilla. Maxilla is a osseous bone which is a paired bone. It has left and right maxilla and it has four processes. The four processes are alveolar process, palatine process, frontal process and zygomatic process. These are paired processes and we must know these anatomic processes in order to inject the local anesthesia to get the area anesthetized. The nerve supply of maxilla is from the maxillary division of the trigeminal nerve, which originates from the trigeminal ganglion, which is located in the Meckel's cave. It has following causes. In the middle cranial fossa, it has meningeal branch. In pterygopalatine fossa, it has ganglionic branches, which has zygomatic branch, posterior superior alveolar branch, spinopalatine ganglion, greater and lesser palatine nerves, and nasal branch, nasopalatine nerve, and pharyngeal nerve. In the infraorbital canal, it has a middle superior alveolar nerve and anterior superior alveolar nerve. On the face, it has infraorbital branch which goes to the inferior orbital canal and gives out the following three branches, which is the inferior palpebral branch, superior labial branch and the nasal branch. So this diagrammatic representation show you the trigeminal ganglion which is situated in the Meckel's cave, from which the three main branches of the trigeminal ganglion are the ophthalmic, maxillary and mandibular nerve. So today we are going to see about the maxillary nerve and its injection technique. These maxillary nerve comes out through the foramen rotundum and mandibular nerve comes out through the foramen ovale. So these maxillary nerve, as soon as it comes out through the foramen rotundum, it gives the ganglionic branch, which is the meningeal branch, and it is the zygomatic branch, which you can see here, zygomatic nerve, and it has the greater and lesser palatine branch, which is here in this area, and it travels through the inferior orbital canal and it gives out as the infraorbital nerve. These infraorbital nerve supplies the face, which is inferior palpebral nerve, and as we discussed in the previous slide, superior labial branch and nasal branch. So moving on to local anesthesia. What is local anesthesia? It was given by Stanley F. Malamet. The local anesthesia is defined as a reversible loss of sensation in a circumscribed area of the body caused by depression of excitation in the nerve endings or in inhibition of the conduction process in peripheral nerves. So, local anesthesia is defined as a loss of sensation in a circumscribed area of a body which is caused by the depression of excitation in the nerve endings or an inhibition of the conduction of the peripheral nerves. So it can be of local infiltration. What is local infiltration? Local anesthetic solution deposited over a small terminal nerve endings. This is the small terminal nerve endings over the terminal nerve endings in an area of the dental treatment. For example, if you want to extract 1-1, which is the upper central incisor tooth, we are going to inject local anesthesia into the small terminal nerve endings, which will anesthetize the tooth of interest, and so that we can perform the extraction of the central incisor uneventfully. Now coming to field block, local anesthetic solution deposited near the larger terminal nerve branches. Local infiltration is small nerve terminal. This is large nerve terminal branch. And maxillary injection administered above the apex of the tooth to be treated are properly termed as field blocks. So this is the difference between the infiltration and the field block. Now coming to nerve block, local anesthetic solution deposited close to the main nerve trunk, usually at a distance from the site of operative intervention. For example, we are going to extract central incisor and we are administering the LA into the infraorbital foramen or into the nasopalatine canal, which is far away from the site of interest. So this is termed as the nerve block. Here we are anesthetizing the main nerve itself. For example, it has posterior superior alveolar nerve and nasopalatine injections. Coming to the various techniques of maxillary nerve blocks, we have intraoral techniques and extraoral techniques. In intraoral techniques, we have posterior superior alveolar nerve block, middle superior alveolar nerve block, anterior superior alveolar nerve block and anterior middle superior alveolar nerve block, greater palatine nerve block and nasopalatine nerve block. An anterior superior alveolar nerve block which can be reached through palatal approach, and maxillary nerve block which can be reached through greater palatine approach or eye tuberosity approach. The first nerve block we are going to see is posterior superior alveolar nerve block, and the areas anesthetized are pulps of the maxillary third, second and first molar only till the mesiobuccal root of the maxillary first molar is not anesthetized, except the mesiobuccal root of the maxillary first molar, remaining all, which is the second, third and distal root of the first molar, it's all anesthetized in the posterior superior alveolar nerve block. And indications of this nerve block is when the treatment involves 2 or more maxillary molars and when supraperiosteal injection has proved ineffective, which means that infiltration or field block has failed to anesthetize the area, we will go for the nerve block. That is, in this case we will go for the posterior superior alveolar nerve block. It also anesthetizes the buccal periodontium and bone overlying these tooth. So here it anesthetizes the third molar, second molar and the distal and palatal root of the first molar. The technique includes its landmarks and how are we going to inject the needle. The landmarks are mucobuccal fold, maxillary tuberosity, zygomatic process of the maxilla. And the target area is the posterior superior alveolar nerve, and the area of insertion is the height of the mucobuccal fold, which is nothing but the posterior most area to the last molar of the maxilla. We will inject the needle into the mucobuccal fold, directing towards the pterygopalatine fossa from where the posterior superior alveolar nerve emerges. And this gives you the infratemporal fossa or infratemporal surface of the maxilla, and distal to the last molar lies the bony protuberance called the maxillary tuberosity. And the procedure involves insert the needle into the height of the mucobuccal fold over the second molar, advance the needle slowly upward, inward and backward direction. Upward, when you inject the needle upward, it should be at a 45 degree to the occlusal plane and 45 degree inwards and 45 degree upwards. And inwards, as soon as you go into the mucobuccal fold, you have to go backward direction towards the pterygopalatine fossa. So there lies the posterior superior alveolar nerve, and the depth of penetration is 16 mm. So 16 mm of the needle should be penetrated into the mucobuccal fold. So we need a longer needle to perform this local anesthetics technique. There is an article in which that they says anesthesia's essays and research, simple and safer posterior superior alveolar nerve block given by Thangavelu et al. In this study, they have given L8 for 200 patients and obtained within a period of 5 to 10 minutes, and no visual complications reported in this study. As I said before, the injection is inserted into the mucobuccal fold, inward, upward and backward at the angle of 45 degree to the occlusal plane. Thus, we inject the anesthesia into that area so that the posterior superior alveolar nerve gets anesthetized, and we enter the needle into the mucobuccal fold in relation to the second maxillary molar. The complications of the posterior superior alveolar nerve blocks involves hematoma. If we insert the needle too far posteriorly into the pterygoid plexus of veins, there lies the pterygoid plexus of veins, which is rich in blood supply. It will get injured and the blood sweeps out of the veins, leading to hematoma formation. A visible intraoral hematoma develops within several minutes, usually noted in the buccal tissue of the mandibular region. So, when there is a hematoma, it signifies that we have gone much deeper into the tissues. And mandibular anesthesia. Close to the maxillary nerve lies the mandibular nerve. So, if you have entered too much posteriorly, it will anesthetize the mandibular nerve as well. So, the deposition of local anesthetic lateral to the desired location may produce varying degrees of mandibular anesthesia. So, we have to be careful. Our target is to anesthetize the posterior superior alveolar nerve, not the mandibular nerve. So, we should stick to the insertion of the needle, the correct angulation of 45 degree, and 16 mm should be inserted into the mucobuccal fold, not more than that. If we go posteriorly, it will lead to hematoma formation, or unadvertent anesthetization of the mandibular nerve. Here is a case report, posterior superior alveolar nerve block, a dilemma for dental practitioners, a case report given by the Swati Gupta et al. Here they have said the complications are hematoma. In hematoma, what are the reasons which lead to the hematoma and how are we going to manage the hematoma? Pressure application. As soon as you see the hematoma formation is there, we have to apply pressure. So this prevents the sweeping of blood from the pterygoid venous plexus. And we have to inform the patient that there is a complication which has happened, so we are going to manage it. So this will calm the patient and it will make the patient understand what has gone wrong. And immediate application of ice is mandated, and heat application is considered after 4 to 6 hours and the next day also we can keep the heat application for 20 minutes. And it is prudent to prescribe antibiotics. We should give antibiotics as the sweepage of blood might cause infection. Time is the most important factor in the management of hematoma. With or without treatment, hematoma will be present for 7 to 14 days. So if you don't manage it immediately, it will last for 7 to 14 days. So swift management of the hematoma is mandated. Now moving on to the next nerve block, which is the middle superior alveolar nerve block. The middle superior alveolar nerve block is present in only about 28% of the population. So as we all know, in posterior superior alveolar nerve, the mesiobuccal root of the first molar is not anesthetized. So here this middle superior alveolar nerve supplies the pulps of the maxillary first and second premolar, especially the mesiobuccal root of the first molar. The buccal periodontal tissues and the bone over these same teeth are anesthetized. Here you can see buccal root of the first molar and first and second premolar are anesthetized in the middle superior alveolar nerve. Indications are where the anterior superior alveolar nerve block fails to provide pulpal anesthesia distal to the maxillary canine. So anterior superior alveolar nerve block, when it fails to anesthetize the canine tooth distal to it, premolar, first premolar and second premolar, then it will lead to the failure of the ASA. So we will go for the middle superior alveolar nerve block. Dental procedures involving the both maxillary premolars mandate the middle superior alveolar nerve block. The technique. Here the landmark is the mucobuccal fold above the maxillary second premolar. The target area here is the maxillary bone above the apex of the maxillary second premolar. Area of insertion of the needle is height of the mucobuccal fold above the maxillary second premolar. So once you take the local anesthetic injection, inject it into the mucobuccal fold, which is here, and direct it upwards into the height of the mucobuccal fold. There we will inject the needle and administer the local anesthetic solution. This local anesthetic solution will anesthetize the middle superior alveolar nerve. The procedure, as you can see, this is the second premolar, maxillary second premolar, and it is given into the mucobuccal fold. Height of the mucobuccal fold, the injection is inserted. Insert the needle into the height of the mucobuccal fold above the second premolar with the bevel directed towards the bone. Always direct the bevel of the injection towards the bone and penetrate the mucous membrane and slowly advance the needle until its tip is located well above the apex of the second premolar. Here also the complications are hematoma, and we will manage it by applying pressure with sterile gauze over the site of swelling and discoloration for a minimum of 60 seconds. For about a minute, we will keep the pressure into the area so that it will prevent the hematoma formation. Now coming on to anterior superior alveolar nerve block, which is also known as the infraorbital nerve block. The nerves anesthetized here are the anterior superior alveolar, middle superior alveolar and the infraorbital nerve. As I said before, it has three branches, which is the inferior palpebral, lateral nasal and superior labial. The areas anesthetized here are the pulps of the maxillary central incisor to canine on the injected side. So from the central incisor to the canine, and it also involved the first and second premolar to the mesiobuccal root of the first molar, along with the buccal soft tissues, and the bone over these teeth are also anesthetized. And infraorbital nerve is also anesthetized, so it will anesthetize the lower eyelid, lateral aspect of the nose, which is lateral nasal nerve, and the upper lip, which is the superior labial nerve, are also anesthetized with this nerve block. The techniques. First, landmarks. Each and every injection techniques acts as landmark, target area, area of insertion and procedure. In this technique, we are going to see the landmarks, which is the mucobuccal fold and the infraorbital notch and the infraorbital foramen. We will keep the patient in a supine position and we will palpate the infraorbital notch which is the inferior orbital rim. Just below the inferior orbital rim, there is a depression which forms the infraorbital notch. Just below the infraorbital notch lies the infraorbital foramen through which the infraorbital nerve comes out. The target area here is the infraorbital foramen, as I said before, through which the infraorbital nerve comes out. The area of insertion of the needle is eye of the mucobuccal fold directly over the first premolar. So here you can see the depression in the inferior orbital rim, which is the infraorbital notch, and just below that is the infraorbital foramen. The procedure is feel the infraorbital notch and move your finger downward from the notch to palpate the infraorbital foramen. And the bone immediately inferior to the notch is convex. This represents the lower border of the orbit and the roof of the infraorbital foramen. As your finger continues inferiorly, a concavity is filled. This is the infraorbital foramen. Here we have to inject the needle eye into the mucobuccal fold, just distal to the canine and mesial to the first maxillary premolar. The needle is inserted into the infraorbital foramen to anesthetize the inferior orbital nerve. The infraorbital nerve block anesthesia extended coverage using intraoral molar approach given by Kumar. This article says that a line is drawn from the frontonasal, which is the glabella point, infraorbital depression and the zygomatic buttress to the second molar. A line is drawn with the injection to the occlusal plane. This forms a 65-degree angle and this gives you the point of needle insertion. So exactly into the angle formed by this line, two lines, we will insert the needle in the 65-degree angle to anesthetize the infraorbital nerve. As you can see in this picture, the needle is inserted at the height of the buccal vestibule in the first molar region in an upward and an inward and backward direction. So the classical technique is injecting the needle between the canine and first premolar. Here this modification gives us the angle, a line drawn from the glabella and the infraorbital depression and through the zygomatic buttress, this is the zygomatic buttress, into the second molar of the maxilla, and in conjunction with the occlusal plane an 65-degree angle is made. So the needle is injected into the mucobuccal fold along the first molar. So we will reach the point infraorbital foramen though the injection is deposited over there. So it will anesthetize the infraorbital nerve. The technique here, it's the occlusal plane is at 45 to the floor and the operator stands at 9 o'clock position with the thumb placed on the infraorbital foramen to palpate the exact point of insertion. And here the needle is advanced slowly in a upward, inward and backward direction, passing anterior to the zygomatic buttress to form an angle of 65 to the maxillary occlusal plane. With the bevel facing, always the bevel should face towards the bone. 1 ml of solution is slowly deposited at the foramen. The needle is withdrawn while depositing the local anesthetic solution. A 0.7 ml is deposited halfway and another 0.5 ml at the point of entry. So thus achieving the infraorbital nerve block. Here the complications are hematoma, which is very rare and it might move towards the lower eyelid also. The management is similar. Apply pressure on the soft tissue over the foramen for 2 to 3 minutes. The anterior middle superior alveolar nerve block given by Friedman and Ockman. Here the areas anesthetized are pulpal anesthesia of the maxillary incisors, canine and premolars. The buccal attached gingiva and the attached palatal tissues from the midline to free gingival margin on the associated teeth are also anesthetized in this nerve block. Indications are when anesthesia to multiple maxillary anterior teeth is desired. So if we have to extract multiple teeth in maxillary anterior area, we have to give multiple infiltration injections, which will be very discomfortable for the patient. So we will give this anterior middle superior alveolar nerve block to anesthetize the wide area or wide range of teeth in order to perform the procedure. When anterior cosmetic procedures are to be performed and a smile line assessment is important for a successful outcome, this nerve block is indicated. The technique, as I said before, it involves landmarks, target area, area of insertion and the procedure. Here the landmarks are the intersecting point midway along a line from the mid-palatine suture to the free gingival margin intersecting the contact point between the first and second premolar. So a line is drawn in the mid-palatine suture and an intersecting line which is drawn between the first and second premolar of the maxilla. So this is the point where we are going to inject the LA to anesthetize the anterior middle superior alveolar nerve. The area of insertion is on the odd palate about halfway along an imaginary line connecting the mid-palatine suture to the free gingival margin, which is located between the first and second premolar. The procedure is very slowly advance the needle into the tissue, then always the bevel should face towards the bone, and orientation of the needle from the contralateral premolar is mandated. We can't go on the same side of the premolar, we should come from the contralateral side from the opposite premolar to inject the local anesthetic solution. Here the complications are palatal ulcer. Because the palatal mucosa is tightly adhered to the palatal bone, any separation from the bone, it will cause a detachment from the bone and leading to a hypoxic or ischemic state, leading to the devascularization, and slowly it will cause an ulcer in that area. So palatal ulcer at the injection site, which will develop for 1 to 2 days post-operatively, which will heal on its own within 5 to 10 days. The prevention of this palatal ulcer formation is by slowly administering the LA local anesthetic solution and avoid excessive concentration of vasoconstrictor, which will prevent the hypoxia or ischemic state of the palatal mucosa. Avoid multiple injection injuries at the site of injection. So we have to find that anterior middle superior alveolar nerve to inject it into the correct area rather than giving multiple injections, which will lead to palatal mucosal ulcer. This article says that a comparison of the anterior middle superior alveolar nerve block and the infraorbital nerve block for the anesthesia of maxillary anterior teeth given by Ian Corbett, it says that the infraorbital nerve block produced anesthetic success in canine and premolar teeth with a more rapid onset than compared to the anterior middle superior alveolar nerve block. Although the anterior middle superior alveolar nerve block was significantly more successful than infraorbital nerve block in attaining incisor anesthesia, it was inefficient for central incisors as assessed according to the rigorous electronic pulp testing. Therefore, the infraorbital nerve block is much more better and efficient than the anterior middle superior alveolar nerve block. Coming to the greater palatine nerve block, which is situated in the palatal mucosa, and the areas anesthetized here are the posterior portion of the odd palate and its overlying soft tissue, anteriorly as far as the first premolar and medial to the midline. The indications are when the palatal soft tissue anesthesia is necessary for restorative therapy of more than 1 or 2 teeth for pain control during periodontal or oral surgical procedures involving the palatal soft and hard tissues. So here you can see the area that are going to be anesthetized after greater palatine nerve block or the palatal mucosa from the first premolar to the last molar, and this is your greater palatine foramen through which the greater palatine nerve comes out. This technique involves the target area of greater palatine nerve and the landmark is the greater palatine foramen found palatal to the second molar and junction of the maxillary alveolar process and the palatine bone. So this is the maxillary alveolar process till here, and this is the palatal bone, this area. So this is situated at the junction. Exactly here the greater palatine foramen is situated through which the greater palatine nerve comes out and it supplies the molar, premolar, okay. The area of insertion is soft tissue slightly anterior to the greater palatine foramen, and path of insertion is advance the serrage from the opposite side of the mouth at right angle to the target area. The procedure is the location of the greater palatine foramen. Sometimes it's difficult to identify the greater palatine foramen, and based upon the ratio and the percentage of the location of the greater palatine foramen, the measurements have been given by Malamed. The location of the greater palatine foramen anterior half of the second molar is 0%. When compared to the posterior half of the second molar, it is 63 times it has been found, and it's a percentage of 39.87%. Mostly it is situated in the anterior half of the third molar, accounts for 80 numbers, which is 50% of the time it is found in the anterior half of the third molar. When compared to posterior half of the third molar, it's just 15 number and it accounts for the percentage of 9%. So now we can easily identify the greater palatine foramen, which is majority of the time it's situated in the anterior half of the maxillary third molar. Another article given by Nidhi Sharma says that the anatomy and the anesthetic consideration of greater palatine nerve block in Indian population, they have studied 198 sites were measured, and most common location of greater palatine nerve block is situated in the third molar tooth area. And the opening of the greater palatine canal is onto the odd palate was observed to the anteromedial in cases of 60% of the cases. Majority of the cases it is found in the anterior third of the maxillary third molar, which accounts for 71.21%. So the location of greater palatine foramen is in the anterior third of the maxillary third molar. Here you can see this is the mid palatine suture, and this is the anterior third of the maxillary third molar. So the greater palatine foramen is situated here. So in majority of the cases, the location of the greater palatine foramen is in the anterior third of the maxillary third molar. Coming to the procedure, direct the syringe into the mouth from the opposite side. If you are anesthetizing right side, you should inject the needle from the left side of the mouth into the greater palatine foramen. The depth of penetration is usually about 5 mm. Here the complications are, as I said before, palatal mucosa tightly adhered to the palatal bone, so it will cause ischemic damages to the palatal mucosa. Ischemia, necrosis of the soft tissues. When highly concentrated and quick injection of the local anesthetic solution was administered. The hematoma is possible but rare. So in these cases, hematoma is rare because of the tight adher palatal mucosa. Another article which says that the J.G. McCann gives that local anesthesia in palate, a comparison of techniques and solution. He said that the infiltration and the greater palatine nerve block anesthesia to compare lidocaine with lidocaine plus epinephrine as palatal soft tissue anesthesia. The response to the sharp probing and pressure pain thresholds did not differ between the palatal infiltration and the greater palatine nerve block. Over the period of 1 hour, the greater palatine nerve block and the palatal infiltration provide similar soft tissue anesthesia. Either with lignocaine with epinephrine produces long-lasting soft tissue anesthesia than plain lignocaine following the palatal infiltration. So there is no change in palatal infiltration and greater palatine nerve block. With lignocaine, it is reduced with lignocaine and epinephrine. Because epinephrine acts as a vasoconstrictor, it will prolong the duration of the local anesthesia. Now coming to the nasopalatine nerve block, the areas anesthetized here are the anterior portion of the odd palate, which is soft and odd tissues. Bilaterally from the mesial side of the first premolar to the mesial side of the other side of the first premolar. So this is the mesial side of the first premolar on one side to the mesial side of the first premolar on the other side. This area is anesthetized completely with the help of the nasopalatine nerve block in the palatal region. Here the techniques are landmarks, which includes the central incisors and the incisive papilla. The target area is the incisive foramen beneath the incisive papilla. Just in the palatal area between the both central incisor, we will inject the needle through a soft tissue bulge will be there. This marks the incisive papilla. Just into the incisive papilla, we will inject the needle to reach the incisive foramen through which the nasopalatine nerve comes out. The areas of insertion is the palatal mucosa just lateral to the incisive papilla, located in the midline between the two central incisors. The path of insertion here is the 45-degree angle towards the incisive papilla. Lateral to the incisive papilla, the injection is inserted. The procedure, first we will identify the incisive papilla. So this bulge of tissue is the incisive papilla between the two central incisor, and the injection is inserted lateral to the incisive papilla to reach the incisive foramen, and the nasopalatine nerve is anesthetized. There are two techniques, one single needle penetration and the other one is the multiple needle penetration. The single needle penetration is directly injecting the needle into the incisive foramen to anesthetize the nasopalatine nerve. The multiple needle is both labially and palatally we will inject injections to make it less painful for the patient. The complications here are ischemia, necrosis of the soft tissue while using high concentration of vasoconstrictor. Hematoma is possible but very rare, and interdental papilla between the maxillary incisors sometimes are tender for several days after the injection. Though the soft tissue is tightly adhered to the odd palate in the anterior region, the injection might cause the tenderness over the area where the local anesthesia is injected. So it will be lasting for few days and it will recover on its own. Another article from the Journal Maxillofacial and Oral Surgery, Sundar Raman Prabhu gave that making nasopalatine blocks much more comfortable for the patient, a randomized prospective clinical comparison of pain associated with injection using an insulin syringe and a standard disposable 3 ml syringe. So as I said, the palatal mucosa is tightly adhered. It is very painful for the patient when you administer nasopalatine nerve block. So in order to prevent or make it less painful for the patient, they have done a study in which they compared insulin syringes, which is just 1 ml syringe and it has a very thin needle compared to the normal disposable needle, which is slightly bigger than the insulin needle, and the syringe size is for 3 ml. And they concluded the study by saying the use of insulin syringe as a relatively painless alternative to the standard manual devices used for administration of nasopalatine block. So they said, in the study they have said that the insulin syringes are much more effective and less painful for the patient while administering the nasopalatine nerve block. Coming to the anterior superior alveolar nerve block through palatal approach. The areas anesthetized are the nasopalatine area and the anterior branches of the anterior superior alveolar nerve. And the areas anesthetized are pulps of the maxillary central incisors, the lateral incisors, and to lesser degree the canine is also anesthetized. So both the central incisor along with canine to a lesser extent are anesthetized with this technique, and the facial, which means the labial periodontal tissue, and the palatal periodontal tissues are also anesthetized along with the teeth. Another article given by Ram et al., the assessment of palatal approach of anterior superior alveolar nerve block with the VAND in pediatric dental patients. The study concluded that same effectiveness was achieved with VAND and the CBI, which is a maxillary anesthetizing technique. The children displayed better behavior during injection when they received local anesthesia with the VAND than they did with the CBI was used. They did not scratch the upper lip, nose, or cried after the treatment when they received the injection technique and the palatal approach of anterior superior alveolar, whereas they did when receiving a CBI. So the conventional buccal infiltration technique was less effective when compared to the periodontal ligamental injection using the VAND injections. So VAND injection is nothing but it's a computerized device to inject the local anesthetic solution. So it was much effective when computerized device like VAND was used as a periodontal ligament injection compared to the conventional buccal infiltration technique. So the children presented with much more compatibility and less side effects like scratch over the upper lip, nose, or crying during the procedure or after receiving the injection was much more less in compared to conventional buccal infiltration technique. So the indications are when bilateral anesthesia of the maxillary anterior teeth is desired from a single site injection. When anterior cosmetic procedures are to be performed and a smile line assessment is important to a successful outcome, we will carry out this nerve block technique. When a facial approach, supraperiosteal injection has been ineffective because of the dense cortical bone. Anterior maxilla has dense cortical bone, so the infiltration technique often fails. So we will go on with this nerve block technique to achieve the utmost anesthesia of that area. The area of insertion is just lateral to the incisive papilla in the papillary groove, similar to the nasopalatine nerve block. The target area is the nasopalatine foramen and the landmark is the nasopalatine papilla. The procedure is rotating the needle allows the needle to penetrate the tissue more efficiently and it's less painful for the patient. Continue the slow insertion technique into the nasopalatine canal. Orientation of the needle should be parallel to the long axis of the central incisor. This is the central incisor and this is the incisive papilla. The needle is inserted along the long axis. It should be parallel. So the needle is inserted like this, parallel to the long axis to the central incisor. The needle is inserted lateral to the incisive papilla and the needle is advanced to the depth of 6 to 10 mm into the nasopalatine foramen. Here the complications are palatal ulcer at the site of injection post-operatively. Prevention is by slow administration. We have to administer local anesthesia slowly to avoid excessive ischemia, avoid excessive concentration of the vasoconstrictor. density of soft tissues at the injection site causing sometimes the local anesthetic solution may squirt back. So in order to avoid it, slow administration is mandated. In this original article given by Pragati Raghavendra et al., palatal approach of anterior superior alveolar injection technique may not be potentially useful in periodontal procedure. Why? Because this study suggests that the conventional palatal anterior superior alveolar injection technique does not provide anesthesia for more than 20 minutes when compared with the conventional anterior superior alveolar nerve block. So, the conventional palatal anterior superior alveolar injection technique is of very short duration and does not demonstrate any effectiveness in the periodontal surgery of the anterior maxilla. So, we have to go for conventional anterior superior alveolar nerve block when we are performing periodontal surgery of the anterior maxilla. Coming to the maxillary nerve block, here we have seen the branches of the maxillary nerve. Now we are going to see how we are going to anesthetize the entire maxillary nerve all together in a single injection. Areas anesthetized here are the pulpal anesthesia of the maxillary teeth on the side of the block, buccal periodontium and bone overlying these teeth, soft tissue and bone of the hard palate and part of the soft palate medial to the midline, skin over the lower eyelid, side of the nose, cheek and upper lip, all are anesthetized in this area. Basically, whatever the nerve blocks we have studied so far, it's all anesthetized all together with a single injection, and we are anesthetizing the entire maxillary nerve. The indication is the pain control before extensive oral surgical or periodontal procedure, when tissue inflammation or infection precludes the use of other regional nerve blocks or supraperiosteal injection. Diagnostics or therapeutic procedures, neuralgias of the second division of the trigeminal nerve. Here you can see the entire teeth, buccal and palatal soft tissue along with the teeth are anesthetized with the single injection of the maxillary nerve block. The techniques are greater palatine approach. In greater palatine approach, how are we going to anesthetize the maxillary nerve? The target area is the maxillary nerve. As it passes through the pterygopalatine fossa, the needle passes through the greater palatine canal to reach the pterygopalatine fossa. The landmark here is the greater palatine foramen, which is majorly situated at the anterior third of the maxillary third molar. The area of insertion here is the palatal soft tissue directly over the greater palatine foramen. After locating the foramen, very slowly advance the needle into the greater palatine canal to a depth of 30 mm, which is 3 cm we have to insert the needle. So here the needle is inserted from the opposite side. Here we are anesthetizing the left maxillary nerve. So we are coming from the right side. After locating the greater palatine foramen, the needle is inserted into the greater palatine foramen at about 30 mm or 3 cm. The complications associated with the maxillary nerve block anesthesia via greater palatine canal are we might inject the local anesthetic solution into the pterygoid venous plexus, and it might cause nasal bleeding, penetration of the nasopharynx, diplopia, strabismus and ptosis. Diplopia is double vision, strabismus is paralysis of the eye, and ptosis means drooping of the upper eyelid, and injury to the neural tissue. And injury to the neural tissue means that the sudden or forceful injection of the local anesthetic solution will injure the nerve tissue, and anesthetic failure. If you don't enter the target area, there will be failure of the local anesthesia. So the areas of interest will not get anesthetized. So we will have a failure of the local anesthesia with this technique. So always after inserting the needle, aspirate to check whether the needle is into the target area or into any blood vessels. The positive aspiration with blood indicates that the needle is into the blood vessel. The other technique is the eye tuberosity approach. The first technique is through the greater palatine foramen. The second technique is through the eye tuberosity approach. Here the landmarks are the mucobuccal fold at the distal aspect of the maxillary second molar. As I said before, maxillary tuberosity is nothing but the bony protuberance which is situated distal to the last molar. So this is the maxillary tuberosity area. And the target area here is the maxillary nerve as it passes through the pterygopalatine fossa, superior and medial to the target area of the posterior superior alveolar nerve block. The area of insertion is the height of the mucobuccal fold above the distal aspect of the maxillary second molar. Here, the article given by Thangavelu et al. States that to evaluate the intraoral eye tuberosity maxillary nerve block technique in the zygoma and arch fracture, reduction and fixation. So in case of zygomatic bone fracture, we can give maxillary nerve block in order to reduce and fix the zygomatic bone. The blocks were effective and the patients were comfortable without any pain during the initial stages of the surgery, but in later stages, 2 patients had mild to moderate pain. The maxillary nerve block is a good alternative option in selective cases of zygomatic bone fracture reduction. So we all know that the injection is inserted into the target area, which is the pterygopalatine fossa, and we are inserting the needle through the height of the mucobuccal fold over the second maxillary molar and just lateral to the posterior superior alveolar nerve. The needle is inserted and the local anesthetic solution is administered. Here the complications are penetration of the orbit. If we go so high into the mucobuccal fold, we might reach the floor of the orbit, leading to the orbital complications or ocular complications such as ptosis, diplopia, strabismus. The periorbital swelling and proptosis. Proptosis is the bulging of eye out of the socket, and periorbital swelling is swelling around the orbit area. Regional block of the 6th cranial nerve producing diplopia. So the 6th cranial nerve, which is the abducent nerve, gets anesthetized, so that's why there is diplopia, which is double vision. And sometimes there might be optic nerve block also, which might lead to the transient loss of vision. So we have to be careful with the maxillary nerve block technique, especially the eye tuberosity technique. And possible retrobulbar hemorrhage. Retrobulbar hemorrhage is nothing but the vessels which is situated posterior to the eyeball. When it gets injured, it will lead to the sweepage of blood into the posterior part of the eyeball. So it will lead to the continuous blood sweepage, leading to the life-threatening condition, or it might lead to loss of vision permanently. Second, the penetration of the nasal cavity. On aspiration, large amounts of air appear in the cartridge, which indicates that the needle is inserted into the nasal cavity rather than the target area. On injection, the patient complains that the local anesthetic solution is running down into his throat. Prevention: keep the patient's mouth wide open and take care during penetration that the advancing needle stays in the correct plane. Do not force needle if resistance is encountered. The maxillary nerve block, a comparison between the greater palatine canal and the eye tuberosity approach. The two techniques what we discussed on anesthetizing the maxillary nerve block, we come across this study where they have compared both the greater palatine canal and the eye tuberosity approach. This shows that the greater palatine canal approach ensures effective anesthesia in the posterior maxillary region as far as both the dental pulp and the palatal vestibular mucous membrane are concerned. The eye tuberosity approach did not guarantee adequate anesthesia of the pterygopalatine branch of the maxillary nerve. These regional anesthesia techniques were characterized by a low incidence of intra and post-operative pain. So they say the greater palatine canal approach is much more effective than the eye tuberosity approach because it is less complications are associated with it, and it's more effective in giving the desired anesthesia we require. Now moving on to the extraoral technique. Whatever we have seen is the intraoral technique. Now we have come to the final part of the class, which is the extraoral technique. The extraoral infraorbital nerve block or the extraoral maxillary nerve block, these two techniques are given extraorally. The extraoral infraorbital nerve block, which is given by extraorally, here the area anesthetized are the complete anesthesia of the teeth and facial structures of the anterior part of the maxilla. Indications are when multiple extraction is required in the anterior part of the maxilla, or surgical removal of the impacted teeth, especially the impacted canine, surgical exploration of the anterior part of the maxilla, endodontic surgery in the anterior part of the maxilla, and treatment of acute trauma requiring suturing of soft tissue or repositioning of the alveolar bone and associated teeth or bone. So in the face, infraorbital rim, and it's the infraorbital notch. Just below that is the infraorbital foramen through which the infraorbital nerve comes out. So extraorally we are going to administer local anesthesia to anesthetize the lower eyelid, lateral nose and the upper lip area, along with the teeth, anterior teeth, labial and palatal soft tissues. The technique here is the target area is the infraorbital foramen, which is located 5 to 10 mm below the inferior to the zygomatico-maxillary suture. The area of insertion here is just below the operator's palpating infraorbital foramen. So we have to inject the needle just below the infraorbital foramen. The needle was inserted through the skin and directed upward at a 45-degree angle. So first we have to palpate the infraorbital rim, which is the lower border of the orbit. Then the foramen is palpated, and this is the operator palpating the infraorbital foramen, and the needle is inserted upward. So the needle is inserted upward at a degree of 45-degree angle over the skin into the infraorbital foramen. So the complications here are bruising or bruising in the infraorbital area would be highly visible. So the skin discoloration will be there, and there will be hematoma formation over the area of injection, which is very common with this nerve block technique, and there will be soreness after the injection is administered. If the anesthetic solution should inadvertently enter the orbit, a transient diplopia loss of vision is anticipated. So if rather than injecting the needle here, if we inject little higher above, if the needle enter the orbit, it will lead to diplopia. Diplopia is caused by the anesthesia administered to the lateral side, anesthetizing the abducens nerve, causing diplopia, and loss of vision is caused by optic nerve, because the anesthetic solution administered will sweep into the optic nerve, leading to transient loss of vision. The other extraoral maxillary nerve block are the suprazygomatic approach. Here the nerve anesthetized are maxillary branch of trigeminal nerve. The entire maxillary nerve is anesthetized with this technique. Here the point of insertion is the skin projection of the frontozygomatic angle. This is the frontozygomatic angle. So this is the zygomatic bone, and this is the frontal process of the zygomatic bone. So the point of entry of the needle is injected here. So this is above the zygomatic bone, that's why it's called suprazygomatic approach. And the target area here is the foramen rotundum. As I said earlier, the maxillary nerve comes out through the foramen rotundum. After confirming the needle was in contact with the greater wing of sphenoid bone, it was advanced through the infratemporal fossa, angulated at approximately 60 degree and 10 degree towards the sagittal plane and horizontal plane respectively. When the rubber marker of 50 mm, which is 5 cm, reaches the skin, the patients were instructed to warn the surgeon when they feel the local anesthetic dropping into the nose or throat, which means that we are going beyond the target area. This meant that the tip of needle had reached the posterior wall of the pterygopalatine fossa and penetrated the nasal mucosa. As I said before, this is the frontal process of the zygoma, and this is the zygomatic bone. This is the frontozygomatic angle, and just beneath that we are injecting the needle. About 5 cm of the needle is inserted, and it is inserted to the pterygopalatine fossa to anesthetize the maxillary nerve. The needle was then withdrawn for 3 to 5 mm to avoid intranasal injection. The remaining drug was slowly deposited into the vicinity of the foramen rotundum, where the maxillary nerve leaves the base of the skull to enter the pterygopalatine fossa. If the complications are hematoma, ecchymosis, which is nothing but the blood sweepage into the subcutaneous plane causing discoloration of the skin, visual disturbance, as I said before, diplopia, transient loss of vision, limitation of mouth opening, that's because of the mandibular nerve sometimes might get anesthetized, or deviation of the lower jaw is also seen. The other technique is the infrazygomatic approach. What we saw earlier was suprazygomatic approach. Now we come to infrazygomatic approach. Earlier the injection was above the zygomatic bone, now it is below the zygomatic bone. The mandibular fossa between the condylar and coronoid process of the mandible is the area of insertion. The target area is the pterygopalatine fossa. There the needle of insertion was close to the foramen rotundum. Here we target the pterygopalatine fossa. So this is the zygomatic bone. This is the zygomatic bone. This is the condyle of mandible. This is the coronoid process of mandible. This is the mandibular notch or sigmoid notch. Our area of interest is here. Between the two process, into the sigmoid notch below the zygomatic bone is the area of insertion. A skin infiltration was given, followed by that the 6 cm needle is introduced at an angle of 45 degree in the direction back of the eyeball. So at an angle of 45 degree, the needle is inserted towards the back of the eye, pointing towards the back of the eye. The needle is inserted. 4 to 4.5 centimeter, the lateral part of the pterygoid process is reached, and the needle is withdrawn slightly in the pterygopalatine fossa, about 0.5 centimeter medial to the pterygoid. So we will insert the needle, 6 centimeter needle is inserted, and we withdraw the needle to 4 to 4.5 centimeter to reach the pterygopalatine fossa. Aspiration in various level is mandated so that we ensure that the needle is not inserted into the blood vessels. Here the complications are transient visual weakness, as I said earlier. Diplopia or transient loss of vision is noted. Horner's syndrome, nothing but the ptosis, drooping of the upper eyelid, which is extremely rare. Hematoma over the cheek. Wherever we have injected the local anesthesia, there is skin color change due to the sweepage of the blood into the subcutaneous plane, which can be corrected by applying pressure or keeping cold pack. So to summarize, we have seen the various maxillary nerve block technique. It can be intraoral or it can be extraoral. In intraoral, we have seen various greater palatine, nasopalatine, posterior superior alveolar, middle superior alveolar, palatally given anterior superior alveolar and anterior middle superior alveolar nerve blocks. Various maxillary injection techniques we have seen. Extraorally, we have seen infraorbital nerve block along with that maxillary nerve block, which is suprazygomatic and infrazygomatic approaches also seen in this class. Thank you students for watching my video.